helps you, and you can see how quick it is to bring up the thumbnail. You can see the thumbnails. The main success there has been a approximate 95% reduction of disc fractures. We're looking at impact of orthopedics.
Welcome everyone, I am Stefan Romein from RBfracture, the most comprehensive overview of all the commercially available AI algorithms in radiology. And we understood from our users they would like to see more practical examples of how these applications are being used in clinical practice. And that's why we're trying something new, product review videos. Videos in where we interview end users on how they are using these applications in their clinical workflow. And in this edition, we focus on RBfracture, a fracture detection tool from Danish company Radiobotics. This is an AI application and computer-aided detection software aiming to assist healthcare professionals in reviewing trauma skeletal X-rays. And the intended users for these applications are healthcare professionals that are reviewing these cases in different clinical settings, including emergency care doctors, radiologists, and reporting radiographers. And the intended patient population age for this application is patients starting with the age of 2 for fracture detection and effusion detection, and patients with the starting with the age of 15 for dislocations and lipohemorrhages. And today we welcome Ben Madden from University Hospitals of Northamptonshire. Ben is already using this product for several years in his clinical practice. And in this video, together with Ben, we will go over the adoption process, his experiences, and also a small demo of the product, and the impact he sees in clinical practice. So thanks a lot for being here, Ben. Can you give us a brief introduction about yourself and your role within the department?
Hi, my name is Ben Madden. I'm the lead reporting radiographer at Kettering General Hospital, and I manage a small team of 6 reporting radiographers and deal with the onboarding of certain projects as well.
Perfect. Thank you very much, man. Looking forward to hear your insights. So to get started, why did you actually start exploring AI applications for the fracture detection use case?
So we wanted to improve ED X-ray trauma turnaround times, and we also wanted to look at reducing ED misfracture rates. We did look at hot reporting, but it wasn't financially viable. So this is when we started looking at AI products that could help us out.
So it was both for the turnaround times and reducing the missed findings.
Yeah, although technically it wouldn't reduce turnaround times because it wouldn't be seen as an official report, but at least it was something ED could look at and start managing if we deemed it to be accurate enough as such.
Exactly. And also what we see currently, so we see already more than, I think, 5-6 applications out there on also Health AI Register on fracture detection. How did you select RBfracture? So what were the key decisions in that?
There was a few trusts that already had RB on board. We got good feedback from that. Also, when you're Googling and trying to find all these different systems, RB was always top of the list. So in discussions with RB and a few others, it was the feeling they gave us and the turnaround in questions they gave us, the speed at which they go back to us, the feeling of there's no sell pressure. It was very much a conversation about how we could implement this, and they were very, very good about funding a trial with us to have a look and prove its accuracy.
Also, I'd like to hear your experiences also in really using this product in clinical practice. So maybe can you share your screen and show us an example of how you're using this product in your clinical workflow?
Yeah, absolutely. So here we see a lumbar spine X-ray, an AP projection and a lateral projection. We then, when RB analyzes these images, it will bring back a summary report, which we can see here. And if there's a positive finding on the summary report, it will then give you a secondary capture of the image in question, and it will draw a bounding box around that area it wants you to look at in more detail. Whenever it's a dashed box, then it's less sure. And if it's a solid box, then it's more confident of that. So this then draws your attention to L3 transverse process, which we can see there's a fracture. We bring it up on the AP. We can see there's a fracture through that transverse process. It has missed the fracture the transport process of L2, but when you start looking at L3, it's very easy then to see the L2 fracture as well. So this helps you, and you can see how quick it is to bring up the thumbnail. You can see the thumbnails there, and you can see it's got a big red dot on it, which draws your attention to it, that you need to look harder.
Yeah, so in this one, indeed, it really helps you in the report. How do you do that? So do you first look at the image itself and then at the AI output, or how do you have to see that?
Yeah, I mean, it depends how you report, but me personally, I would like to look at the x-rays first, have a good look over them, and then as some sort of comfort blanket, then look at RB's analysis, and whether I need to then look further or I can move on with as I thought. I have a negative case here where we can see that pelvis and a lateral projection, and then we see in negative cases there is no secondary capture apart from the summary report, which is a dulled out dot, which you can then see, yeah, it's assessed it as normal. I don't need to look any more detail. I think it's normal. We can move on.
Oh, that's interesting. Do you also have the information in your work list available at this point?
At this point, we have an old system, PACS and RIS solution, so we can't use the AI to triage the x-rays for us. But going forward, we'll get upgraded and it will incorporate within that, and we can use it to triage, and it will bring up all the fractures to the top of the list, and we can then go through and report straight away.
Exactly. Yeah, that's something you need to implement in the upcoming future when it's possible in the PACS.
Absolutely, yes.
All right. And the first one you also showed that it missed a finding. We all know, of course, that AI is not perfect. So how do you deal with that in clinical practice?
So if it's, in this case, it's if it misses a fracture, then when we report it, we have an audit system in the background. So when we report it as there is a fracture, and RB called it not a fracture, we have an audit phrase at the end where ED can then pick it up and then change their management if required. But any x-rays that are missed, and there seems to be a trend in it missing fractures, for example, lateral hips can be a problem depending on condition of the x-ray. We then report that back to RB, and they always have a solution, be it short or medium term, to work on to improve that accuracy. And there's things we can do as well, especially if it's projectional or exposure wise or something like that.
Okay, I understand it correctly. So you then, of course, use the AI output in your reporting, but you still look at it yourself. And also you close contact then with Radiobotics to also show them these missed findings, and there's a sort of system in place also to monitor this performance over time for this application.
Yeah, ED are advised that the official radiology report is gold standard, and it's not something that you rely on too heavily. You just use it as a guide. And we have a safety audit in place that ED do every day, and they pick up on any fractures that we call.
How do you work with the ED department in this? So do you as radiographer always look first at the image and then the ED doctor? How do you do that?
So especially in the evenings and nights, the ED clinician will be looking at the image first, and then the next day we will pick it up and report it. Usually somewhere between the 12 to 16 hour range, we'll report it with him. So they're usually, in a lot of the cases, especially at night, they will be managing the patient based on their clinical opinion and also RB's opinion. And then the next,
they do also have access to this RB output.
Yes, they do. Yeah, they have the secondary capture as well, so they can act on that straight away. But during the day, if there's any query between RB and their opinion, they call us and we then give the official report.
And if we talk about also the integration into the workflow, so what we normally hear, it can be quite challenging as well to do the data orchestration. So to really make sure only the fracture cases, potential fracture cases, will be forwarded to the algorithm. How do you do that in your clinical practice?
Yeah, it can be tricky when you're initially setting up, because you don't really foresee a lot of these issues. But it all depends whether you're sending from the X-ray modality itself, or whether you're initiated by some sort of PACS button. Over time, we've realized that talking to RB, they've helped us out quite a lot with extra filtration on our gateway, our side. That means it blocks things like chest x-rays, facial bones, cervical spine from getting analysed, or at least a secondary capture coming back to our PACS in a way, because it can, especially on abdomen x-rays as well, it can cause confusion.
And based on the DICOM text, you then have an automatic workflow to automatically forward the right cases to the algorithm, or do you have to do that manually?
So at the minute, we're running off modality. We will be moving to a PACS-based solution, but at the minute it is via the modality. So literally everything goes to the gateway. Gateway then filters it, and then the right exams then go to the RB server, and they get bounced back.
And can you tell us a bit about the impact you see in clinical practice? Have you been able to quantify that as well?
Yeah, so we've looked at an awful lot of metrics, but the key take-home metrics are that it's 94 to 95% accurate, and 2, it's reduced ED misfracture rates by 94%, which is quite a staggering amount. In our trial period, it was a 63-64% reduction, but going forward after that, we found it has reduced to 94%. So it's quite staggering. And now we're working on how we work on, because the key take homes for most trusts who want to onboard a system like this is how much is it going to cost me, and how is it going to save that money for me? And that's what we're working on at the minute, to see how long it would take for a normal trust to pay back the subscription fee for this system.
Oh, that's interesting information. That's something now you also want to publish online in the upcoming future.
Yeah, hopefully soon. But you know how these things go.
And then we talk about the key features of this application. So what do you see as the key features that really makes it worth using for you in your clinical practice?
So honestly, it has less of an impact when you're an experienced reporter. It's more for ED clinicians, and you could say junior reporters could find it quite useful as well. When you're a experienced reporter, it's less useful, but it does have the main perk for it for a reporter, and this is a big perk, is kind of like the main errors that you can do as a reporter is satisfaction of search. You see one problem, you finish, you're done. But there could have been another issue, another fracture maybe. Or if you've got a foot x-ray, sometimes you don't look to the peripheries of that x-ray, and you can miss a toe fracture, for example, which isn't very clinically relevant, but nonetheless it's a fracture. And even in this case that I'm showing, it was quite easy to miss these transverse process fractures, but this is where it's useful in those cases where you wouldn't expect necessarily a fracture to be there, and it's drawing your attention to that area and you're giving it a second look. That's when we find it really useful.
And how was the adoption process in your department? So, of course, sometimes can be difficult to really truly adopt and let everyone use it in clinical practice. How did you see that?
Well, first I found ED were really supportive. They're really great. As a reporter, we're all very skeptical, and it took a while, especially at the start where the system wasn't as good as it is now, for us to trust it and believe in it. But now I think we're all there. So the adoption process is pretty quick, really, because it's a tool there to help. You could ignore it if you wanted to, but it's always advantageous to have a look at these things. Come to your own conclusion.
If you could give them any advice, Radiobotics, or what should they improve in that product?
They do need to look at the lateral hip to see if there's anything they can do there. Every radiology department needs to also look at what they can do there as well in terms of improving radiographic practice, exposures, making sure patients are appropriately dressed before arriving in the radiology department. All these things help RB, and then RB are always doing something in the background. to improve their weak areas. And when we say weak areas, the lateral hip came out at about 92% accurate, where it was the average was 94% to 95% accurate. So it's not very far away, but obviously the lateral hip is a very significant area.
And also to try to wrap up, so is there anything else that you would like to share to the audience, maybe to also help them ensuring a responsible adoption of AI in their clinical practice?
It was very challenging getting this over the line. I think if you're thinking about AI and implementing it in your department, then I think it's very important to reach out to your digital team for the policies behind that. Also to reach out to governance as soon as possible. As soon as you can get that ball rolling, the better. IT department, see how you're going to implement this. I think if you start initiating there, then you will quicken the process up significantly.
So to really have this AI team on site with the different backgrounds from clinical, technical, regulatory to really drive the process forward. Really interesting insights. Thank you very much, Ben. And as I said, this is new, so we're also happy to hear the feedback from the audience. Happy to hear other questions that we should ask in next series, or maybe other products that we should cover in the next series. And I'm already looking forward to the next one. Thank you very much.